Hi, we're the group doing Parkinson's disease. I'm Jill.
Hi, I'm Brianna.
Hi, I'm Miranda.
And then I'm Rachel.
And for an optimal learning experience, make sure that you put your headphones in so you can hear us. Believe it or not, April is Parkinson's Awareness Month. Woohoo! So I have some facts here directly from American Parkinson Disease Association. You may not know, might find interesting. So, first off, Parkinson's impacts more than 1 million Americans, more people than ALS, MS, and muscular dystrophy combined. So having more of an understanding and awareness of Parkinson's is going to be really important for us as the nurse because it impacts so many. Incidence of Parkinson's increases with age, but an estimated 4% of people with PD are diagnosed before the age of 50. Men are 1.5 times more likely than women to have Parkinson's, sorry guys. And it can impact nearly every area of health, from moving to speaking to thinking clearly. And at some point in this presentation, you'll hear me talking about nursing management and our role as the nurse for Parkinson patients, and the different people that we collaborate with to improve the quality of life for these patients. And finally, the cause is unknown and there is no cure. So there's still a really long way to go with Parkinson's, but having this awareness and understanding will only help improve our education and research with this topic.
Okay, so first we're going to start by talking about the pathophysiology of Parkinson's disease. In Parkinson's disease, there are changes in the brain, and these changes play a role in the development of this disease. We know the pathophysiology of what happens during Parkinson's, but we don't know the true etiology. But research supports that there is a genetic component, or that there are some viruses or toxins that can actually trigger Parkinson's disease. There are 3 changes that occur in the brain with the development of Parkinson's disease. 1, there is a lack of dopamine. Dopamine is the neurotransmitter that is essential for normal functions of our extrapyramidal motor system. It controls posture, support, and voluntary motion. So the easiest way that I remember this is remembering the key signs and symptoms that we'll talk about on the next couple of pages. Second, a degeneration occurs of the dopamine-producing neurons in the substantia nigra of the midbrain, which results in a disruption in the balance of dopamine and acetylcholine in the basal ganglia. So, you think that you are never going to remember the substantia nigra, the midbrain, or the basal ganglia? Well, if you refer to the picture of the healthy brain and the brain with Parkinson's disease on the bottom of the slide, you'll see an area of red near the center of the brain, and what this is showing us is the dopamine activity is drastically reduced in those Parkinson's disease in the center of the brain, which contains our substantia nigra, our midbrain, and our basal ganglia. So if we remember that all of this dopamine activity is being lost in the center of our brain and we know the anatomy, we're going to remember those. An interesting fact is that it also takes a loss of 80% of the neurons in our substantia nigra to produce manifestations of Parkinson's disease. So by the time we see these manifestations, 80% of the patient's neurons are already gone in their substantia nigra. Third and final, the next change in the brain is the presence of Lewy bodies. So it's unknown why these Lewy bodies, which are just unusual clumps of protein, even form, but it is known that when these little Lewy bodies are present, that abnormal functioning is present in the brain. All right, now remember, nursing students, there is no dope in the park. This is the simplest way to remember the basic pathophysiology, which is the lack of dopamine in Parkinson's disease. All right, so now that we know the pathophysiology, the next question is, what are patients with this disease going to display? The signs and symptoms of Parkinson's disease include a triad of symptoms that include tremors, rigidity of muscles, and bradykinesia. If you don't think this is something you could ever remember, just remember the red bar. T is for tremors, the first sign that appears in the triad of symptoms. This patient will start to notice that their handwriting is affected, even if it isn't obvious to anyone else. Tremors also includes pill rolling, which is when the thumb and forefinger are literally moving in a motion that would be as if one is rolling a pill between them. R is for rigidity, the second sign of the triad. This is when the patient will start to have jerky movements when moved passively. This occurs because in a patient with Parkinson's disease, there is sustained muscle contraction, which will also lead to muscle soreness, feeling tired, or even pain. Consequently, the actions of this patient are going to be slower than those of a healthy person. B is for bradykinesia, the third sign of the triad. It includes the loss of autonomic movements, which comes from the chemical alterations that are in the brain. Now, what are the two main chemical alterations? Yes, a lack of dopamine and a disruption in the balance of dopamine and acetylcholine. This will be displayed as stooped posture, a masked face, drooling, and a shuffling gait. So it's important for us as nurses to remember that we don't only need to be aware of these motor signs and symptoms, but we also need to be aware of the non-motor symptoms that might follow. These can include depression, anxiety, apathy, fatigue, or even a change in their sleeping. Now it's time to listen to Miranda about the management of care for patients with Parkinson's disease from the role of the nurse.
Hey guys, I'm going to be talking about the management of care for the patient and what the nurse's role is. So there's four main areas that I want to focus on, and that would be med administration, therapy collaboration, safety, and patient well-being. So for medication administration, it's important for us as the nurse to understand the mechanisms of the drug along with their adverse effects so that while we're monitoring our patient, if we notice anything going on, we can treat them early on. And also any drug contraindications and what can happen if they have those. So on the top right, I included a picture of vitamin B-rich foods, which are foods that we want to avoid. If these foods are in their diet, it will decrease the effects of their meds. And so patient education is important with teaching them what they can and cannot eat while they're on their Parkinson drugs. Also, something with medication administration that I wanted to mention is a caution for dysphagia. So dysphagia is having trouble swallowing, and as the disease progresses, they have different signs and symptoms that we talked to in the prior slides, and rigidity and tremors play a big part in that dysphagia. And so in this picture, you can see that someone that's drinking some water that has those types of signs and symptoms can go straight down their airway because they aspirate that and into their lungs instead of down their esophagus. So some tips and tricks for that issue would be not using a straw with patients who have trouble swallowing, and getting a swallow eval would be really important for a Parkinson patient. And also, if their meds can be crushed or put in applesauce, something like that, to try and reduce any possible risk of aspirating anything into the lungs, because that's just going to give us more problems and we don't want that. Okay, so moving on to therapy collaboration, we're going to be working with a lot of different people to improve the quality of life of Parkinson disease patients. So with the speech therapist, they'll be working with the volume of their voice and the ability to continue to communicate. And then with the occupational therapist, they'll be working on ways to adapt to the changes in their everyday activities and their activities of daily living to improve the quality and the safety of those. And then also, we'll be working with physical therapists. And as you can see, I put this super cheerful granny over here, and the effects of exercise in Parkinson's disease is astronomical. And of course, for every individual, exercise is important, but it's extremely vital for people with Parkinson's. And I have some facts from Parkinson.org that I'd like to tell you. So research has shown that exercise can improve gait, balance, tremor, flexibility, grip strength, and motor coordination. And also, there's a strong consensus among physicians and physical therapists that improved mobility decreases the risk of falls and some other complications of Parkinson's. So they agree that practicing movement, physical therapy, occupational therapy, and participating in an exercise program improves mobility. And that is going to be huge with Parkinson's disease patients, depending on where they are at in that progression, to encourage safe independence. So all these different people that we'll be working with will be on board to help them have that independence but have the safety along with that. and that means seeing if they may need an assistive device like a cane or a walker, and those types of things to make sure that they're safe. Okay, now moving right along to safety. While they're in the hospital, we are going to be initiating a fall risk with these patients just based on the types of meds that they're on and also with the signs and symptoms of Parkinson's. So we'll be making sure that we have that bed alarm in place, making sure that the call light is in reach and doing patient education for how and when to use the call light. And I put here assistance with eating if needed. That's completely depending on where they're at in that progression, but we can delegate that to the PCT to help them eat. And use of assistive devices while they're ambulating. And of course, yellow socks and a yellow fall wristband. I have this picture down here. That's the universal color for a fall risk patient. And then something important to think about with Parkinson's disease patients is that we want to allow periods of rest throughout the day. It's not a good idea to bundle all of our care at once, so spreading it out throughout the day is going to be better for these patients. And I have elimination training on here. If they're further along and they're having troubles with that, we're going to be rounding every other hour along with the PCT and just asking them if they have to go to the bathroom and helping them to either a bedside commode or, the bathroom. This will allow for a more routine type of elimination pattern, which is always going to be beneficial for an elderly patient. Okay, and finally, moving on to patient well-being. So this is a progressive disease and there's no cure. So the patient is dealing with all these changes in their life, and that's hard to deal with. So being there emotionally and offering support for our patients will be really, really beneficial to them. Also, we can ask for social work to come in and talk to them if they need it. We don't need a doctor's order for that. And also giving them the right resources so that they can help cope with their disease. Okay, thanks guys.
So as future nurses, one of the most important things for us to know is what medications do we use in order to treat Parkinson's disease. So right now, let's start with anticholinergics. So we all know a lot about anticholinergics. We use them a lot in a lot of different disease processes and different things. So we're really familiar with them by this point. So really what I want to do is I want to focus on how do we use them in the treatment of Parkinson's disease specifically. So they work by blocking the action of acetylcholine in the central nervous system to help normalize the acetylcholine dopamine balance. They are used obviously in the treatment of Parkinson's disease and the relief of those extrapyramidal symptoms, which, if you don't know, the extrapyramidal tract controls those involuntary movements that help regulate movements and temperature and positions and things like that, those unconscious adjustments. Moving on, we have some contraindications with the use of anticholinergics. Obviously, if you're allergic to it, don't use it. It's also contraindicated in narrow angle glaucoma, GI obstruction, and prostatic hypertrophy. We also want to use caution when using these in patients who have dysrhythmias, hyper or hypotension, hepatic dysfunction, and pregnancy and lactation. And with pregnancy and lactation, it's really going to be risks versus benefits. So, what are the risks? Do the benefits to the mom outweigh the risks to the baby? So, our adverse effects with anticholinergics. I know we all know the saying for the side effects that are contributed with anticholinergics: the can't pee, can't see, can't spit, you know the rest. So, really, what I want to focus on is the adverse effects that you will see specifically with our Parkinson's patients. So you will see some disorientation, confusion, agitation, delirium, some nausea and vomiting. I want to move over to this photograph right here on the right. It talks about cogentin, which is a popular anticholinergic used in treatment of Parkinson's disease. It's available PO, IM, IV, but mainly what I want to point out is the need to assess our elderly patients for confusion, disorientation, and agitation, and psychotic-like symptoms. So agitation is huge. I remember in MedSurg 1 clinical last semester, I had a patient who had been admitted with Parkinson's crisis, which is basically just the exacerbation of Parkinson's symptoms, which can occur after like an illness or a sickness or anything that kind of throws their body out of whack, they can kind of go into this Parkinson's crisis. And this lady, I mean, she was very feisty and she was very angry and obviously really uncomfortable and unhappy. She didn't really like any of the nurses or the doctors or anybody that would come into her room. She was very agitated, and I just remember the doctor and the nurse kind of trying to figure out, like, okay, what's going on with this patient? Is this an effect of her medication? Is this her baseline mental status? Is like what's going on here? It was kind of hard to put the pieces together because she didn't have any friends or family um, in the area to kind of say like, hey, this is what happened. So they were kind of trying to, put the pieces together as they went along, and she had just been admitted and put on the floor from the ER. But she was a very classic Parkinson's patient. She had the shuffling gait and the tremors and all of it. But the good thing is that she did like NIU students. She did like nursing students, so it was quite nice for us, at least, because we were one of the few people that she was actually nice to. So some drug-to-drug interactions are the tricyclic antidepressants, the phenothiazines, and I also just threw in some facts about anticholinergics. Just a fun fact is that anticholinergics are the oldest drugs used to treat Parkinson's disease, so one of the first used to treat Parkinson's disease. And also, these drugs are most helpful in young patients who complain of tremors, those extra pyramidal symptoms.
The next category of drugs is dopaminergics. The most commonly referred to dopaminergic is levodopa. The action of levodopa is to increase the level of dopamine and stimulate the dopamine receptors in the brain. This drug is obviously used to treat the signs and symptoms of Parkinson's disease. Levodopa shouldn't be used if the patient has an allergy to the drug, if the patient has narrow-angle glaucoma, if the patient has a gastrointestinal or genitourinary obstruction, or if the patient has prostatic hypertrophy. Caution should be used in patients with arrhythmias, hypertension, hypotension, hepatic dysfunction, pregnancy, and lactation. If you're unsure about a contraindication, it is always best to seek additional information. Better safe than sorry. Adverse effects of dopaminergics can include dysrhythmias, nervousness, restlessness, anxiety, and even paranoia. Adverse effects can also include blurry vision or a headache. Drug-to-drug interactions include vitamin B6 because the levodopa effect may decrease and then an increase of Parkinson's symptoms could occur. Drug-to-drug interactions also include MAOIs or monoamine oxidase inhibitors. Taking these two drugs together could cause toxicity. Something special to note is that levodopa is almost always given with carbidopa. This is because then less levodopa is needed to have a therapeutic effect on the brain.
Thank you for watching until the end. If you say the secret code words Goddard and Gemini,
then you will receive a delicious surprise.
Come see me in class for a piece of candy.